Welcome to the webinar, OTC Medication Behaviors of Older Adults, developed by the Gerontological Society of America, GSA, in partnership with the Consumer Health Care Products Association, CHPA. They'll have a question and answer session immediately after the live presentation. My name is Steve Albert. I'm one of the speakers in today's program, along with Dr. Mary Bridgman and Dr. Michael Wolf. I myself am professor and chair in the Department of Behavioral and Community Health Sciences at the Graduate School of Public Health at the University of Pittsburgh. I'm joined by Mary Bridgman, who is a clinical assistant professor in the Department of Pharmacy Practice and Administration at Rutgers, the State University of New Jersey, and the Ernest Mario School of Pharmacy, and also internal medicine clinical pharmacist at the Robert Wood Johnson University Hospital. Along with Mary is Michael Wolf, who is Associate Professor of Medicine and Associate Division Chief of Research in General Internal Medicine and Geriatrics at the Feinberg School of Medicine at Northwestern University. We're very excited to be part of this important program. At this point, we're going to take a quick segue to a poll in which we just will get a sense of the audience for these webinars. The poll is open, and if you would, you should be able to just indicate your connection or affiliations for this webinar, and it'll help give us all a feel of who's listening in. Please take a minute to fill out the poll. Okay, let me just give you a quick summary in case you can't see it. It looks like about 3/4 of the attendees are GSA members, another 7% from CHPA, 2% from both, and 17% from neither. So we have a nice diversity there. And thank you again for joining in. Let me move right away into the agenda for today's meeting. You can see we're going to cover a lot of ground, and we don't have a lot of time. So we're going to just give you a flavor of the sorts of things our work group has been developing, remembering throughout that the idea is to develop a more sophisticated science of OTC medication behavior. And I think you're in for a treat as I give you a little bit of background first on how we got to this webinar. If we could have the next slide. So this is the product of, as we've mentioned already, between GSA and CHPA. What you're hearing today is the result of a summit that we had in mid-April in Washington, D.C. We had 46 attendees from industry, academia, and practice together to evaluate the state of research on OTC medication behavior in older adults and to identify gaps in the evidence base. To get to that point required quite a lot of preliminary work by our work group, which consisted not only of the speakers you'll hear today, but a number of other people, and let me just quickly acknowledge them. Margaret Dyer Chamberlain from Stanford, Laura Bix from Michigan State, and Patricia Nefschi from the University of Connecticut. And we needed to have a great diversity of talent for this effort, and included in the expertise of our work group were everything from cognitive psychology to pharmacy packaging to technology interventions to promote adherence. We're going to cover health OTC medication literacy, some of the perceptual and cognitive bases we think relevant for OTC medication decision making, the interface between clinical and family care and OTC use, as well as time permits some technologies that are being developed to support optimal OTC behavior. The goals of the summit are outlined on the next slide. And basically, it was to develop the science of OTC behavior to support safe and effective use of these medications. And we think one of the great outcomes of this effort would be to recruit a cadre of behavioral scientists with appropriate expertise to work in this critical and we feel neglected area. We have some other goals as well. I've mentioned a few already, and I think you can just take a quick look at these as our speakers will be covering these topics. The program in the Health Summit, which took place in April, consisted of the following, shown in the next slide. We have a section on OTC medication behavior, a section on the context in which people learn about OTC medications and decide how to use them, and finally a section on developing technologies to support safe and effective use. You can see some of the speakers there, and I hope if you'll attend the GSA in New Orleans, which is upcoming in November, we'll be having a symposium to further develop these ideas. Let me show you also on the next slide what's going to happen following our webinar today. I mentioned already our GSA annual meeting symposium. We're preparing a publication from this effort, and I think you're going to see some interesting additions to the GSA website in this area. So at this point, let me hand over the microphone to Dr. Michael Wolf from Northwestern. He's going to talk about OTC use among the elderly with a focus on health literacy. Michael, if you would.
Thank you, Steve. So my role is really to run through a good deal of content in a short period of time, as was mentioned earlier, and I'm going to do so as quickly as I am able, and also hoping to get questions at the end as necessary to answer or kind of clarify anything I might not have spent as much time on as I should. So just to kick it off, a lot of the work that our research team, among many others over the past 2 decades, have been focused in on is health literacy, which kind of comes in a lot of different flavors, as this slide kind of highlights, you know, in many different names: health communication, patient adherence, activation, numeracy. A lot of it all comes down to really understanding how people problem solve and engage in a variety of healthcare tasks that get imparted to them by a healthcare system. Next slide. If we can move on to the next slide. Sure. And the reason there's been nearly over 600 original research studies that have really focused in on this, and the majority of these studies have played a greater emphasis on older populations, has been just the business case that it does seem to make an impact, as many studies to date have shown. Really, that what we know is that patients who have low health literacy, or maybe less skill and knowledge and experience in navigating a variety of healthcare tasks necessary to manage their health, have inadequate or inaccurate knowledge of their disease and treatment, have poor self-care skills that include medication use, monitoring, and device use. Studies have shown also that it leads to inappropriate health services use, and ultimately low health literacy translates to non-adherence to recommended treatments, costly urgent services, medication errors, and adverse events, which have been less studied to date, but also ultimately poorer outcomes that have been studied in a number of chronic conditions. Next slide. So this all kind of leads into what we know is that 1 in 5 adults severely lack the cognitive and psychosocial skills needed to manage their personal health. And the greatest risk has been among those who are over the age of 60, have less than high school education, are racial ethnic minority groups disproportionately are represented from those groups, specifically Hispanic and African American, and those with multimorbidity. Prior studies also suggest that physicians and nurses and pharmacists, among other healthcare professionals, cannot easily identify these patients in clinical practice, and therefore you find them ultimately combined with the fact that we also know that patients with low health literacy or less familiarity or knowledge or engagement in their health care, as we refer to in the specific context of low health literacy, these patients often are not, because of stigma or because of awareness, not self-identifying themselves and asking questions and letting health professionals know that they also are confused. And again, this in this context of this seminar might be reflective of whether or not who is going to be asking physicians and talking to patients, talking to the providers about over-the-counter medications that they self-select and purchase on their own, or even asking a pharmacist at the time of a potential OTC purchase any questions about the product. So next slide. Just another quick comment just to highlight why specific to this seminar, this webinar, and to the elderly, data has consistently shown that older adults lack literacy proficiency or health literacy proficiency and are disproportionately affected by limited health literacy skills. But interestingly enough, if you look at some of the questions specifically around OTC use that were embedded in the National Assessment of Adult Literacy and Health Literacy back in 2003, you found that older adults, or those over the age of 65, performed more poorly on average when asked the question to perform basically by identifying 3 substances that may interact with an over-the-counter drug to cause a side effect using information on the over-the-counter label. So again, just on basic proficiencies that involve OTCs, we have some evidence to support that, again, elderly may lack the health literacy skills necessary in this context. Next slide. Some of the work that we've also done that kind of try to look at the underlying causes of this. So why would the elderly be disproportionately affected by limited health literacy? And there's a few reasons that are suggestive of that. One, there's a generational component where, if you believe that, educational attainment oftentimes is a strong predictor of health outcomes, and from a generational standpoint, you see that older adults, come from an era where the high school graduation rates were less, quality of education as well might be reflective of it. So on average, high school graduation rates beyond that, and also just average educational attainment is lower. But also, there's a cognitive component to it, which is the issue of decline, where fluid abilities, in this case, consistently decline, actually starting at a much, much earlier age. In young adulthood, many fluid abilities kind of peak and start to decline and make it even more impactful on decision-making and processing of a lot of health information. So next slide. But you also can't just focus in on individual ability, and this is what a lot of health literacy research has kind of tried to focus in on, and not just potentially focus on the issue of the level of cognitive skill or ability. It's not just about that, but also it's about what the demands of the task are. So, the health literacy task of OTC use is actually quite diverse and complicated. An individual has to, when you deconstruct what's involved in and decision-making and use of an OTC, there's a lot of different components that make this particularly challenging. So everything from one, an individual has to appropriately recognize the symptoms that they're experiencing so they can then go ahead and self-select an over-the-counter product that would be right for them to treat those symptoms. Then, obviously, for safe use and for vigilance purposes, what we've been seeing, especially, everything from This American Life that came up this weekend to, the many, many stories around issues like acetaminophen use, which I'll talk about a little bit later. Knowing active ingredient is an important part of using an OTC and making sure that you know what you're taking, despite brands and symptom marketing that makes it oftentimes confusing, or that maybe it's less salient to know what's actually in the product just by knowing the name of the drug or the brand. But you also have to know proper dosing. You have to be aware of concomitant use warnings, and you have to know when to stop. That this is not necessarily, these are medications that fit mostly as a PRN product, that they're not for oftentimes extended use, at least many of them aren't, and that kind of issue, especially as it's being brought into an oftentimes complicated drug regimen of prescription products, how do you work this in? Next slide. Beyond even just that task that the patients have to perform, there's a lot of things that further complicate it, including the number of product choices that we have available, that there are branded generic options, single and multi-ingredient products that, again, convolute this notion of being aware of active ingredient. You have problematic labeling, with many studies showing variable and poor quality information and instructions that are placed on a label, whether it be on the front of the package, within drug facts, which, again, studies have numerously shown that that is a difficult table and format for consumers to navigate, and that you have container versus package issues as well, where oftentimes information that goes on a container that might be in a larger font, or in other words, maybe more prominent, but is the box kept, and what you're left with is the bottle that has, again, much, much smaller font at times. It may be very, very difficult for elderly patients to read and to be aware of. But you also have the time and salience of the product in the labeling itself, because if you've used a product for decades, as it's become familiar to you, then how aware are you of new product warnings and information if it's been changed, because you just assume that you know how to use it. And ultimately, what clearly stands out with OTCs versus prescription products, there's no learned intermediary. So there's no guarantee that a physician or other prescriber or a pharmacist is engaged in the decision-making process or providing any guidance, for that matter, on how a patient is using that product. Next slide. What we do know in determining, looking at problems, and again trying to be mindful of not just the problems of OTC misuse, but specifically in the elderly, is that 42% of older adults use over-the-counter drugs regularly. 1 in 4 adults take more than recommended maximum daily doses for one OTC product, and that was something we just recently studied. Nearly half of adults misuse OTC products by concomitant use, again with pain products specifically under study. And we also found that older age is not necessarily consistently found to be a risk factor, though, to OTC use. Some studies have found that it is, that you do see misuse and confusion around OTC ingredients and products, but many other studies have shown it to be a protective factor, or to level no additional risk. The protective factor might be that individuals, as they get older, they become more familiar with the products and also with medication use as kind of a daily regimen, but ultimately take a more conservative approach in trying to take less medicine. So again, I think that story still remains a little bit unclear as to what additional risk, or what's particular within the elderly population, if there's a subgroup of populations who may be at greater risk for misusing OTC products. But what does matter consistently is other risk factors are male gender, less education, lower health literacy, and less prior experience. Next slide. So here's a slide of just some information that came from, again, a study that was published in the Journal of General Medicine, and also a similar study in the American Journal of Preventive Medicine over the past 2 years, when we started to look at pain relievers and wanting to know if people had the ability to understand double dipping. The idea that one of the things that especially is of concern with many pain products is knowing that with multi-ingredient products that patients, or even just generic and brand products, there's a lot of confusion as to whether or not people actually know the underlying active ingredients, and if they can safely take 2 products with the same active ingredient together. And what we found is an alarming rate of patients misunderstanding, like up to 40% in some cases, as you can see this slide, where a base product like Tylenol rapid release gels was thought that you could also take the arthritis pain relief, so a product that was the same active ingredient, but actually just had a generic brand and it was marketed to for a different symptom, as well as multi-ingredient products or products of a different brand, or even within the same brand, Tylenol PM, that again, it's marketed to symptom. That may be that there's just a great deal of confusion that's caused by the label in thinking about how you could take OTCs safely. Next slide. But the problem, it's also variable as how big a problem this is. The rates of actual overdose, for instance, in the case of acetaminophen, which again has gotten lots of news as of late, are not nearly as high as what we see in hypothetical or demonstrated misuse. So patients may misunderstand, but that's not necessarily always translating to adverse drug events. So we found in a study by Marina Serper at University of Pennsylvania that when she looked at examining actual misuse among emergency department patients who were actually prescribed a prescription product containing acetaminophen, only 2% ever exceeded a maximum daily dose and did not do that frequently. So it wasn't an extended misuse or accession of the maximum daily dose. 11% double dipped. They, in fact, did do concomitant use of 2 acetaminophen products, one being a prescription. And about half were unaware of double dipping with common OTCs. They just did not know that there was a risk of not being able to take a product like Tylenol or another product that contained acetaminophen while taking their prescription product. So that gets us to kind of question what is being said to patients, especially at the time of a prescription, or or otherwise, that kind of highlights the risks of some of these additional tasks of knowing active ingredients and double dipping. Next slide. So there does seem to be a general problem, and as we would find, and that there is a lot of confusion when it comes to the task of OTC use. It's not necessarily clear, if elderly always pose a significantly higher risk, but there's definitely plausible pathways in which they do represent at-risk groups, whether by issues of cognitive decline, lower health literacy, less, variable experience. There can be, and just again, the task itself being unnecessarily complicated. So the question that we often ask is, how can we confuse patients less? So, how could we do things better? It's very clear that we could. So whether or not the elderly are at disproportionate greater risk, they are at risk. Misunderstanding is common among everybody. So what could we be doing about it? And I think there's some lessons that might be learned from prescription products that we could be focused in on. So first off, there is unneeded complexity. Many studies have documented that there's a high level of readability of OTC labeling that needs to be a target. We do know how to actually help patients better understand information by putting more plain language content, but we just haven't done so as of yet. And also the study that we also published and I mentioned earlier in the Journal of General Medicine, we did find that a lot of the root causes to unintentional, misuse of pain products, of OTC pain products, was that there seems to be a focus on marketing an OTC product for the symptom rather than talking about the active ingredient. So again, like the example of a Tylenol PM, which contains acetaminophen, but being marketed as a sleep aid. Do patients understand that versus the same ingredient being marketed for back pain or arthritis or for migraine headaches? That especially with combination products as well, multi-ingredient products also causes a lot of confusion and again kind of masks the notion of a product, containing a same active ingredient to avoid double dipping. And then also a few studies report prevalence of provider counseling. We're talking very, very low rates of counseling and missed opportunities to find ways to kind of routinely educate patients, not just about prescribed medications, but also about medications that they may encounter or regularly use. Again, that is pretty highly prevalent that over the older adults are using these medications in a very common form. So next slide. Another study, another finding from the SERPA study on this counseling aspect that I thought was very interesting is a problem that we found with what patients think their doctors know and what they actually know. So kind of a funny finding here in the slide, for those of you who may recall, it's from the electric company with a little kind of uh-oh task here, is 86% of patients believe their doctor is aware of all OTC medications they are taking regularly. So it seems that nearly all patients think, yeah, my doctor knows the OTCs that I'm taking, but less than half of patients routinely report that they tell their doctor about these OTC medicines. So it's, and we actually did a finding and showed that doctors' offices that use electronic health records, that those patients were more likely to believe so. So there's almost this notion of omnipotence that no matter, even though you're not saying what you're doing in terms of your OTC behavior, you just assume that your doctor is aware of that. So there's miscommunication abroad that we need to fix, both in having patients make sure that they do reconcile their behavior in OTCs with their doctor and pharmacist, as well as having physicians and other healthcare prescribers to be routinely asking patients about their OTC use. Next slide. And again, I'm mindful of time and wanting to make sure I get through just some of these quick evidence in these few more slides. Is, there are things that we can be doing in terms of both helping to improve, whether it be written labeling or information and instructions that we provide guidance to on safe OTC use, as well as spoken communications, and also is leveraging new technologies and other ways to kind of hardwire communication and the public health message of safe use OTCs among elderly patients in particular. But really the evidence is strongest on how we can do better with labeling. We just haven't imparted it, and I know there's a lot of challenges in terms of industry and regulation and whatnot that we have to kind of waddle through, but clearly we do know quite a bit on how to rewrite materials using plain language, how to actually create more suitable content by changing its format and quantity of information, pulling back a bit. And a lot of those best practices, just to be honest, and I won't go through all of them here, just aren't apparent in the current labeling that we see in a lot of these OTC products and prescription products for that matter. ultimately, though, this is just the first start to kind of coming up with these solutions. That redesigning labels is maybe a requisite, but it alone cannot yield the benefit that we're looking for to do more education with consumers and making sure that they take their medications both effectively but also appropriately to avoid harm. Next slide. So I use this slide of drug facts as an example of something that I think a lot of people have many criticisms that they can kind of impart onto it, where this information is often confusing. And while it's standard, and that's the best thing about this, is that you start to have familiarity across all these products, but the content is also maybe not in the most patient-centered manner. Is it sequenced accordingly? Is it justified? Is content justified and explained well? Is there consistency? Is the information actionable? Do we know what to do with this? Is it, our directions, very apparent? Next slide. Despite the problem of having kind of low prevalence of counseling among healthcare professionals to consumers about proper OTC use, we do think that the evidence still needs to be built up a bit more, but we do have some best practices we could be considering. But it's a little bit challenging in OTCs when you don't have a learned intermediary that you can guarantee something to be said. But how do you, provide teach-back techniques when there's not always an opportunity to have a teach-back, where you want patients to confirm how they should be using a product? And so I think the biggest challenge here on verbal counseling is finding opportunity when to counsel patients and to get these conversations started if patients are using these products kind of separated from their medical care. Next slide. A lot of work that we've, again, trying to find the pathway and how this kind of corresponds over with what we've been doing in prescription products is how do you address practice redesign issues to create a hardwiring of consumer education and practice. So, around at the time of a new medication, if you know that there are potential interactions with over-the-counter medications with a prescription product, we can do that quite easily by imparting that language with after-visit summaries, prompting physicians to counsel patients, especially if you imagine if you're prescribed a pain product that contains acetaminophen, and how to avoid use of OTC products that contain are delivered both in print and spoken form. But again, outside of a medical context, whether it be in pharmacy, how can we start thinking about, again, making systematic ways in which we deliver information and content, automate it, so patients do get good messages. And I think that is a challenge, that it's working with prescription products, but OTCs is another matter if you want to talk about OTCs separated from, the risks inherent in with prescription products. Okay, next slide. In summary, and this is my wrap-up, is overall the evidence remains limited and mixed, and there are both problems and solutions that we have. Problems that we recognize that all patients, maybe whether or not the OTC elderly patients are at, have an exceeding risk in OTC use. They definitely, this OTC use, misuse is definitely prevalent among this population, and we do need effective solutions. And there's limitations in how we can infer from other areas of the prescription product. And the potential risks for problems are high. So I think what we do recognize that we want to be able to impart health literacy solutions as best as we can, but also not just focus on an elderly solution, that this is not something that is only an aging problem, but a problem that most patients across the lifespan are going to be faced with lots of confusion around these products in both labeling, spoken counseling, and finding ways to kind of hardwire communications, whether it be in pharmacy or in medical practices or in other non-health contexts, maybe public health campaigns to just get people to be attentive to things around that kind of continuum of the task of OTC use. I'm going to probably stop there and turn it back to Steve.
Okay, thank you. That was Michael Wolf from Northwestern University. At this point, I'm going to turn the rein over to Mary Bridgman from Rutgers. She's going to summarize presentations from Ruth Day from Duke University about decision-making processes relevant for OTC behavior, and also the clinician-patient encounter from Elaine Leventhal from Rutgers, another important area for OTC behavior.
Great.
Mary?
Great, thank you, Stephen. So as Stephen mentioned, we'll next segue into a discussion of the evidence on how older adults make decisions about over-the-counter medication use. Again, as mentioned, the presenter for this session was Dr. Ruth Day from Duke University's Center for the Study of Aging. Dr. Day, in her introductory remarks, informed us that though there has been some research into the decision-making process, the over-the-counter decision-making process of the older adult, there is still much that is yet to be understood about the cognitive processes that are involved in how older adults make these decisions. Specifically, what is known as presented at our conference was largely related to demographic and social factors related to the type of decisions older adults make on over-the-counter medication use. What Dr. Day introduced as being information that's not currently known but could potentially be, including those cognitive factors, the cognitive processes and the decision-making strategies implemented by the older adult when considering and contemplating over-the-counter medication use, how these different factors, the demographic, social, and other factors, interact and interplay in informing someone about making a decision about an over-the-counter medication, and how these individuals respond in controlled situations. As much of the information comes from survey data and what individuals tell us what they do, but not necessarily how individuals react in the controlled laboratory environment. The other point here made by Dr. Day was that much of this information is still in the private rather than the public domain. So there was a call to the industry to consider sharing any information that they might have related to these behaviors if it's at all possible. Next slide. The over-the-counter decision-making process is multifactorial. Examples of decisions that affect any consumer contemplating use of an over-the-counter product, and especially the older adult, include all of those listed on this slide, and no doubt probably many more. Some examples of the types of decisions and the decision-making process that is implemented when deciding to use an over-the-counter medication, including self-identifying whether an individual has a condition that would respond to use of an over-the-counter product. And if that's the case, if an individual can identify themselves as being eligible for self-care, well then what type of product, what specific product, brand, generic, ingredient need they select? How do individuals self-select? How do they identify that they don't have a contraindication to product use, or that they're not taking another medication, as Dr. Wolf pointed out, that might potentially interact with the product in question? And then ultimately the questions relating to dosage and administration of the over-the-counter product. How much should they take, when to take it, how to monitor themselves for therapeutic response. Next slide. Dr. Day also reminded us that decision-making, especially regarding health, is complex, and it involves not just cognition, but also those past experiences and perceptions that we all have. As an example, many of us might perceive the elderly to be slower in making decisions. However, that slowness may not be due to intellect or cognitive dysfunction that may coexist as comorbidities in this population. But that slowness, again, may not be truly related to a pathologic problem, but rather that individual is thinking about those numerous previous experiences before making their health decision at that time. The other thing to consider really are the physical limitations. Other factors that may impact over-the-counter decision-making may have to do with the visual cues and visual problems affecting this population as well. Thinking about visual problems, the need to consider what types of visual problems can happen and what are some of the implications because of these physical limitations. Does the person have a visual condition whereby they're missing words and therefore misinterpreting the content of the label? Or is there a problem with a global problem with vision such that the label is blurred and the overall layout is the challenge? And I'll talk a little bit more about that in the upcoming slide. Depending on the type of visual problem, whether it's macular degeneration or glaucoma or several others, or the organization of the label, as Dr. Wolf pointed out, it has been shown in the literature that older adults may have trouble reading the over-the-counter medication label. And with that, Dr. Day introduced us to some research from her lab. We'll segue into the next slide. As an example of research, older adults' ability to read and interpret data from the drug facts label was subsequently evaluated. And in this particular study, there was specific attention paid to how did older adults really interpret those warnings and that information included on the label. So in this study, they were given time to read the drug facts label and then tested on retention of knowledge of uses, of warnings, and other information they may have gleaned by interpreting the drug label. Next slide. Based on this particular evaluation, we'll go back one slide. When tested for recall of information, it was found older adults were able to identify product uses, but generally very poorly were able to identify warnings or contraindications to use based on the standardized drug facts label in use at that time. And we'll use the next slide with regard to aspirin use to sort of elucidate this. Here's an example of that older label. This was an aspirin-containing product where you can see the stomach bleeding risks are kind of highlighted there in red. They sort of seem to be buried under the warnings for alcohol use and alcohol consumption. So important to the way this information is conveyed in terms of a user being able to self-identify a potential contraindication for use or a potentially serious side effect. And with that, we'll go to the next slide. This was an enhanced version of the label where it became much more prominent and more easily identifiable to the end user that stomach bleeding as an independent risk or as an independent warning. It might potentially alert the older adult cohort who may have other risks for stomach bleeding or previous episodes of bleeding that there might be potentially a drug disease contraindication to use here. I really wanted to point out that a key question arising from this session was in considering how complex the process of over-the-counter medication use is, how can we revise and present information more clearly and more comprehensively to this particular audience or in consideration of the needs of this particular audience. In the next segment, a discussion of the interface between the clinician and the clinical care setting and the promotion of safe and effective over-the-counter medication use was described. Dr. Elaine Leventhal of the Rutgers Biomedical and Health Sciences Robert Wood Johnson Medical School was our presenter here. Next slide. So building on these discussions of both health literacy and decision making, Dr. Leventhal described the concept of the healthy self and how we as humans identify when there is a deviation from health to determine we have some type of illness. The prototypical illness could be a cold, or, do I have symptoms of another more serious condition, be it hypertension, diabetes, cancer, and the like. And the way we sort of identify that as humans, according to Dr. Leventhal, are pattern recognitions. The types of symptoms, the location, have we had these symptoms previously, how fast did it happen, how severe are they? We use this information to create a deliberate response. Do we take a medication? Do we talk to our family members or our colleagues? Do we see a physician? Do we seek medical care? And then how do we ultimately evaluate the effect of our response? Are we better or are we worse after a particular intervention? Next slide. She really describes the patient's acute default model of decision making. I feel sick, I make an action to correct it, and I evaluate whether or not I feel better. Using the example of hypertension, she described how silent, asymptomatic diseases are much more difficult to ensure compliance and adherence to treatment. And we'll kind of segue into the next slide. As an example, in one behavioral psychology study, when patients were told for treatment of blood pressure the medication would affect their perceived symptoms, medication adherence rates were shown to be significantly higher, despite hypertension being a silent, generally asymptomatic condition. So again, you could see a higher percentage when those patients believed that the treatment would influence the symptoms they perceived. A key message from this segment was that in the clinical arena, the clinician must ask questions that will elicit, address, and change patients' misperceptions by communicating a common sense rationale regarding the need for a particular intervention, by eliciting concerns for potential adverse drug reactions and giving patients strategies to manage them if there is an interface with the clinician in the clinical arena, and by making medication regimens as convenient and easy to follow as possible. A very final important point that was made by Dr. Leventhal was really underscoring the importance of documentation of over-the-counter medication use in the patient's electronic health record. We see time and time again in the hospital setting when we go in and try to talk to patients about new medications and the like, the over-the-counter medications, either the patients don't tell us, or as clinicians, we're not necessarily asking the appropriate questions to elicit that information and to include it in the medical record for completeness purposes. And with that, I think I'll turn it back to Stephen.
Okay, thank you. That was Dr. Mary Bridgman from Rutgers University. Thank you, Mary. I have the pleasure now of presenting some of our other parts of our summit. One important discussion was led by Laura Gitlin from Johns Hopkins about the role of family caregivers in promoting safe and effective use of over-the-counter medications. If we look at the next slide here, you can see, I think, that caregiving is prevalent, normative. Some estimates suggest that something like 1 out of 4 Americans is providing some kind of care to a person with disability, an older person with disability. And while we know a lot about caregiving, it's extraordinary that we know next to nothing about the role of lay family caregivers or in OTC purchases and OTC use for an older person, perhaps with disability, in pain or with other problems. And undoubtedly, caregivers go to the drugstore like everybody else and purchase these products. And Laura Gitlin, who knows just about everything about caregiving, said to me that this is probably the first time she's seen a large gap in caregiving research and something that definitely needs more attention. If we go to the next slide, she made a very good case that checking and monitoring symptoms and using medications to address those symptoms really is a feature of caregiving across the progression of care that an older person might need. And this slide shows that even in the earliest stages of caregiving, where care is still sporadic, caregivers, lay caregivers are already checking medications, perhaps administering medications, supplementing them perhaps with OTC products as well. And as the care demands increase and as caregiver involvement increases, certainly a greater role for that medication management follows. And we might add as well that many home attendants are barred from giving medication, and so this turns out to be a key task of lay caregivers. Next slide, please. She presented a little bit of quantitative data from some research from AARP and the United Hospital Fund to show that medication management is probably the #1 prevalent caregiver behavior. Approaching 80% of caregivers do something with medications, although these surveys in the past have not broken out OTC medication behavior from prescription medication. And we're going to recommend as a result of our summit that these sorts of data be collected more routinely in national surveys. And so you can see medication management dwarfs many of the other caregiver behaviors that are chronicled in some of the reports that are available about lay caregiving. So let me begin to make a summary now, because we want to leave some time for questions at the end. But you've heard a ton of information. It might be useful now to pause for a sec and see what we learned from this effort. I think one key problem that comes out with OTC medications, it was mentioned by Dr. Wolf, and this is the question of unintentional misuse. And I think we already have a little bit of a clear pathway to addressing this problem. We need to increase knowledge of active ingredients in OTC products. And maybe one key way to do that is to move away from marketing to symptoms and present something more thorough and more full-grained about what these drugs do. And how to do that is not so clear, especially in the absence of these learned intermediaries such as pharmacists. And I think this is probably a great area of research. We still, I think, have only a hazy idea of the excess morbidity that might come from unintentional misuse. If we could go to the next slide. What came from Dr. Day's presentation quite clearly, I think, is that labels are too complex. And probably we need help from our packaging experts and others to help us, as Dr. Wolf said, quoting Dr. Wood, how can we confuse patients less? And Dr. Day showed us very easily that we can chunk information in more rational ways to simplify drug facts labels, and this would probably make a big difference. And yet we know that boxes get separated from bottles sometimes, and the challenges here are really going to be difficult to address potentially. Next slide, please. A third problem was highlighted by Dr. Leventhal's presentation, which Dr. Bridgman summarized so well, and that is patients are not tabula rasa. They don't come in with a blank slate. They have a common sense model of health and addressing symptoms, and most of those depend on acute care, addressing fever or addressing other short-lived self-limiting problems. And how do we move from that to longer-term medication taking for other sorts of problems like chronic pain? It's not so clear, and we have to remember that we're working with patients who already are experienced drug takers in a lot of ways. Here I think we need great guidance, but certainly better clinician elicitation of OTC medications as part of the patient record would go a long way. I think Dr. Wolf presented very interesting data showing that patients think doctors know which OTC medications they're taking, despite the fact that they don't tell their doctors this necessarily. And so we need to think about ways to make patients more effective partners for promoting safe and effective use of OTC medications. Finally, we heard from Dr. Gitlin that lay caregivers are almost certainly involved in OTC medication. They are gatekeepers for OTC use for more severely disabled older adults. We don't know what kind of guidance these lay caregivers get, and we were unable to identify caregiving interventions specifically to enhance OTC medication behavior to promote safe and effective use. So this strikes me as a very important area for future caregiving research. If we could have the next slide. So in a more general summary, I think we've got great progress and great lines of inquiry ahead of us, but probably many questions remain. Here are a few of them. We don't know what the optimal labeling is yet for OTC medications, although you may want to challenge me in some of your questions later, and I hope you can shed some light on any of these. We still need to learn more about differences between older and younger people in their use of OTC medications. It's still not so clear how to ensure optimal personalized OTC use for any particular adult. It depends much on what other medications and what health conditions people have. It's not so clear still how to integrate OTC medications into the more broad medical management of a person with a number of chronic conditions, as most older people have. And what's the best way to communicate to lay caregivers information about safe and effective use of OTC medications still, I think, is not so clear. So let me move on now and to the last section of our summit, and this involved technologies to support safe and effective use, and they point the way, I think, to addressing some of these issues, though perhaps not all of them. We had presentations from 3 different speakers who have one foot in academia and one foot in medication device development and computer development. This was Dr. Chris Mayhorn, Patricia Meisner, and Dr. Anthony Stearns, all involved in developing devices for reminding and for integrated databases that might be able to accommodate OTC medication, who have all conducted empirical research in these areas. And they made a case for the great promise of new technologies, especially smartphone-based apps, SMS text messaging, and new kinds of integrated databases that would allow a physician or a pharmacist to get a good picture of OTC medication use along with other health information about patients. These have the great advantage of enhanced accessibility to relevant information when and where it's needed, for example, in the drugstore at the point of purchase. And they almost certainly will help support adherence and alert patients to hazards, and will clearly, I think, involve superior monitoring of drug-taking behavior and reconciliation of medications during care transitions. But again, this is not a panacea. There are particular challenges with the older adult who has, for example, visual disorders, and not even the kind we've discussed so far, such as macular degeneration, but other more subtle problems that make use of small miniaturized devices difficult, such as color discrimination or glare problems. Many of these devices involve many sensory modalities, so a person with hearing loss might not be able to use it as well. Of course, there is the cognitive impairment that we see in late age in many older adults. And finally, many of these devices require superior tactile ability, which is sometimes compromised in older ages. So that was a brief run-through of a very productive day we had here in Washington, sponsored by GSA and CHPA. We wanted to toot our horn just a little bit and show you some of the feedback we got from participants. People seemed to like it. They thought it was well done and really generated some excitement about future research and advocacy in this area. We've developed it, and you'll see in our white paper, which will be available on the GSA website shortly, and also in a piece we're preparing for publication, some concrete recommendations to push this research agenda further. And we can talk about some of those in the question and answer period if you would like. But also, I think we recognize, all of us, that one day was not enough. We could only begin to outline the surface of the research required in this area. So at this point, if we could go to the next slide, I just want to give you a little flavor of a publication that will be available on the GSA website shortly. It's one of the hot spots. The white paper on over-the-counter medication behaviors of older adults. It will be emailed to attendees following the webinar. The webinar PowerPoint slides will be available as well. And I would really encourage you to attend our symposium at the GSA in New Orleans in November for a fuller treatment of some of these questions. Next slide, please. We would like to hear your thoughts. You can, there'll be an opportunity, I think, to fill out a survey about the webinar. But now, in our last 5 minutes, you have an opportunity to address any questions to speakers. And if you think we've given short shrift to anything, or if there's some wonderful research out there we don't know about, I would love to hear about it now from you. So let me turn it over now to our audience. And I see we still have over 75 people listening in. So if you have a question, please go ahead and use that chat feature and send it on. Okay, I'm beginning to see some questions. I don't know if we'll have time for all of them. Some of them we've already addressed on the availability of the slides and handouts. But I see one question. Let me start with one that has just come in. The viewer writes, do you think there is any diagnostic yield to ordering acetaminophen levels on seniors who present with unexplained elevation of liver function tests? Good question. Mary, would you like to try to address that one?
Yeah, I'm not aware of any specific literature or data regarding a yield or a clinical utility of specifically ordering an acetaminophen level for seniors presenting with this kind of abnormal presentation, their LFTs and things like that. I think usually what we would do in my clinical environment, we would usually try and elicit as much information as we possibly can from the patient regarding previous medication use. And I think it all starts at least with a good medication history at the very least. Sometimes we'll track down pharmacies and things like that, because you'd be surprised, no, I don't take, I don't take any, other medications, or no, I'm not taking anything. And then you call the pharmacy or whatever drugstore they use, and they're on, statins and other medications as well. So again, I'm not aware of any literature to support the use of that. I think if in your clinical judgment there's a suspicion that that there may be some acetaminophen use or a potential for using a combination product that contains acetaminophen, I think then it's probably warranted.
Good. Thank you, Mary. There are quite a few questions have come in. I'm not sure we're going to be able to cover all of them, but let me take one or two right away. One viewer asks about rural versus urban differences. I think it's a great question. There are many, many differences in prescription use. There are likely to be differences in OTC use as well, and this is a great area for future research. We have another question now about cost factors, and certainly that must also be relevant. We know that many low-income people or folks who don't have good insurance coverage for medication sometimes substitute OTC medications for prescription medications, and this is an area of great interest and probably something to be considered as well. Let me turn to some other questions as well. A number of questions have come in on the role of the pharmacist and how could they have the time to do proper medication review on OTC products when they have hardly time to do it on prescription drugs. And yes, you're right, and this is probably more of a system-level problem that needs to be addressed.
And I think partly regarding that issue, I think the concept of the medication therapy management model and the concept that, for those certain patients who have specific insurance criteria and provision, that they're eligible to come in for that annual med review and get that comprehensive visit with a pharmacist, and the pharmacist is incentivized by also receiving payment for those cognitive services. I think potentially we may see as MTM really kind of takes off and that model evolves, that we may see that and over-the-counter medication use really factored into the complete med histories.
Another question that's come in, thank you, Mary, about the presentation of information in the drug facts, maybe some very simple graphics. Speaking at our GSA panel in New Orleans is an expert on packaging and design issues like this and has done eye-tracking studies to look at what sorts of presentation of this information is most optimal. So I again encourage you to come to the GSA symposium for these sorts of issues. I think our time is up. Unfortunately, it is 1 o'clock now in Washington. I would like to thank all our speakers. I would like to thank all our participants. And I would like to remind you once again that everything you heard today and all the slides that we showed will be available at the GSA website. I would encourage you as well to complete the survey questionnaire, which is attached to this presentation. And I would encourage you as well to go to the GSA website where you'll see additional information about OTC behavior. This is one of a series of efforts we're making at GSA with our partners to begin to look more carefully at OTC medication behavior. So with that, I will sign off, and again, thank you to our participants, and thanks to our sponsors, and thanks to GSA. Goodbye now.